Good afternoon, everyone. My name is Shevaun Harris. I'm the Assistant Deputy Secretary for Medicaid Policy and Quality. We are so glad you could join us. Today we will be discussing medical foster care services in the statewide Medicaid managed care program. In the new statewide Medicaid managed care contracts, health plans are responsible for covering services that were previously only available through the fee-for-service delivery system. These new services include early intervention services, medical foster care, child health services, targeted case management, and nursing facility services for recipients who are not yet enrolled in the long-term care program. The majority of Medicaid recipients receiving these newly covered services are currently receiving their health care services through a managed medical assistance plan. So that means the vast majority of their other health care services are provided through health plans. Today's presentation, as I previously stated, will focus on the transition of medical foster care services into the SMMC program. SMMC stands for Statewide Medicaid Managed Care. There are approximately 300 children between the ages of birth through age 20 receiving medical foster care services. This service is being added to the SMMC program to facilitate an integrated healthcare delivery system where the health plan is responsible for coordinating and paying for all of the services that the child needs. So what is medical foster care? This service provides family-based care for children with complex medical needs who are in foster care, who cannot receive the services that they need safely in their own homes. Medical foster care parents open up their home to these children and are responsible for performing most of the day-to-day functions necessary for the child's care. This includes providing certain medical interventions for which the provider has been trained to perform. One of the benefits of medical foster care services is that it helps to minimize hospitalizations and helps to prevent these children from untoward health outcomes. Medical foster care services is a coordinated effort between Florida Medicaid, the Department of Health, and the Department of Children and Families. So I'm going to describe the role of each party. As it relates to the Department of Children and Families, these children are in the care and custody of DCF. So DCF, through the community-based care lead agencies for which it contracts with, ensures all of the child's needs are met while the child either works on reunification with their biological parent or work on finding a forever home. Florida Medicaid pays for the vast majority of the healthcare services needed for these children. So children in the dependency system are enrolled in Medicaid, and therefore Medicaid pays for all of their healthcare services. The Department of Health operates a medical foster care program, which has historically been responsible for providing the training and oversight over medical foster care services. We will also learn a little bit about the Department of Health's Children's Multidisciplinary Assessment Team process in later slides, where these services are staffed among many interested parties to determine the eligibility for medical foster care services for these children. So the purpose of medical foster care is to enhance the quality of life for foster care children who have complex medical needs, allowing them to develop their fullest potential in a home-based environment. Okay, so some of the features of medical foster care services is that it enables the child to receive their services in a home-like setting. Services are provided in an individualized and personalized way, and it enhances the child's quality of life. So who needs medical foster care services? Children who might need medical foster care services include premature infants who are born with various complications, children with chronic problems such as asthma, children with G-tubes who have little or no ability to intake nutrition by their mouth, children with potential life-threatening illnesses such as HIV or AIDS, cancer, cystic fibrosis, etc., children who have medical problems as a result of abuse or neglect, and newborns who are born drug-exposed and require medication or treatment. So as you can see, the children who qualify for medical foster care services have very complex and involved medical needs, often requiring care from multiple specialists and other licensed practitioners. We're about to watch a video that provides a look into who receives medical foster care services.
I know a place where we can go. I know a place where we can go. I know a place where we can go, not far from here, right on down the road. I know a place where we can go. I know a place where we can go, where the road turns to sand and the grass is waist high and the river is reflected in the blue-winged dragonfly. I know a place where we can go. I know a place where we can go. A blue that connects river to sky, the earth to the trees, you and I know a place.
Okay, so I want to talk to you a little bit about what is included in medical foster care services. So as previously stated, the providers of medical foster care services are responsible for normal duties like the average parent, but they are also paid to provide other medical care needed for the child in accordance with the physician's orders. So services include helping with personal hygiene, continence management, assisting with dressing and feeding and ambulating, transportation and shopping, meal preparation, managing medications, and then advocating for that child in the dependency court hearings or as otherwise needed for the child.
A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P.
The gravity thin as I feel it now. How much you need me to never let you down. Now I finally come to understand, oh, what it means when a life is placed into your hands. You look at me with those trusting eyes. You need someone who won't compromise, constant and steady, with love never ending. With everything that life will put you through, you can find me, I'll be here for you. Constant.
So that video showed you a day in the life of a medical foster care parent and that parent-child interaction that is so important to the success of the program. So below are some of the requirements for a child to receive medical foster care services. So as I previously stated, the child must be in the foster care system. He or she must be under the age of 21 years. He or she must have complex medical needs, must be determined medically stable by a physician and able to receive care in a home setting, and must be determined eligible through the Children's Multidisciplinary Assessment Team. So I'm going to talk more about that team now. So the CMAT, or Children's Multidisciplinary Assessment Team, is responsible for evaluating the clinical eligibility of children under the age of 21 years referred for medical foster care services. The CMAT is administered by the Department of Health Children's Medical Services Office. The CMAT consists of a team of healthcare professionals who recommend a level of care for Medicaid recipients requesting medical foster care services. Key participants of the CMAT include the medical foster care parent, the dependency case manager, the guardian ad litem, the child if he or she is able to participate, and then of course the medical foster care social worker or nurse, and the team itself is led by a physician. The CMAT recommends a level of care based upon the child's acuity needs. The greater the acuity needs of the child, the higher the level of reimbursement that medical foster care parent receives in the fee-for-service delivery system. So here's just a little snapshot of the fee schedule that is used in the Medicaid fee-for-service delivery system. And as you can see, as the acuity level of that child increases, level 1 being the lowest, level 3 being the highest, the maximum reimbursement per day increases with the acuity level. So we're going to talk a little bit about who can provide medical foster care services. So in order to provide medical foster care services, foster home caretakers must meet the following criteria. They must be licensed by the Department of Children and Families. So they have to complete core training on being foster care parents through the DCF. They often have to go through home visiting and meet other core competency requirements just to be a basic foster care parent before a provider is eligible to provide medical foster care services. Then they must complete the medical foster care parent competency-based training through the Department of Health. That is training that is overlaid through the Department of Health medical foster care team to ensure these parents understand the basic requirements of being a provider and the medical responsibilities that are included. But then they must also get child-specific training from the Department of Health to ensure they can provide individualized care based on the physician's order. So once that medical foster care parent is matched up with a specific child, they get specific training on that particular child's needs. And then last but not least, they must be enrolled in the Florida Medicaid program as a provider. Okay, so we're going to transition to the primary purpose of this presentation, which is to talk about the specific transition of medical foster care services into the SMMC program. So I want to reiterate what I stated before, that the vast majority of these children receiving medical foster care services are currently receiving almost all of their health care services, which includes physician visits, home health, durable medical equipment, and other types of services through a managed medical assistance plan. This means that health plans are contractually required to meet the needs of these enrollees now. They are familiar and are competent with serving vulnerable and like populations, such as children who receive private duty nursing or receive medical foster care services. This service is being added to the list of services covered in the SMMC program to continue to facilitate and promote an integrated and holistic healthcare delivery approach. We also want to reiterate that foster care parents should also be very familiar with engaging with health plans now, as the health plan is responsible for furnishing, again, a vast majority of the health care needs. So this means that foster care parents are used to calling the health plans to engage them in the full continuum of healthcare services that that child needs, including making sure that if there are any issues in the provision of care, the health plan is apprised of that information. I also want to state that an overwhelming majority of these kids are currently in the Children's Medical Services Plan or in the Sunshine Child Welfare Specialty Plan. The remaining kids are served by other health plans. That being said, the agency is taking great care and caution to make sure that all health plans are abreast of what the requirements are and that this is a smooth transition. That segues nicely into our transition goals. So the agency has established goals for this transition that ensures continuity of care for recipients, as that is of our utmost concern. So key tenets or goals for the transition of this service into the SMMC program includes that there will be no disruption in care. Current medical foster care parents will continue to get paid, and we'll talk a little bit about that later. No child will have to change their health care plan or transition to a new setting, meaning a new home, as a result of this transition. And health plans will adopt administrative simplifications to ensure a smooth transition and ongoing operations in the delivery of medical foster care services. While many of these kids are being served by the two plans that I mentioned, again, we are taking great care to ensure all of the health plans are prepared with the requirements of this population in the event they are assigned a child needing medical foster care services. One of the concerns that we have heard is that children in the CMS plan will have to switch plans, and that is not true. Children will not have to change plans as a result of this transition. We recognize that the processes in place now that facilitate the delivery of medical foster care services were put in place for a reason. The goal of this transition is not to disrupt that which is working, but rather complement the existing structure that's in place. So to ensure smooth transition, the agency has specific requirements that the health plans must meet related to the CMAT staffing meetings, service authorization, care coordination, plan of care development, the service delivery model, provider network requirements, continuity of care, and provider reimbursement. By the time I walk you through each of these areas, hopefully you will see the important role and contribution that the health plan will have in assisting the current parties involved in providing medical foster care services, but you will also see that a vast majority of the processes that are in place are not changing. So let's start with the CMAT staffing meetings. So the CMAT staffing meetings are the entry into getting medical foster care services. Currently, the agency has a nurse who participates in all medical foster care CMAT staffing meetings. We are delegating our role on the CMAT to the health plan for their members being reviewed. We feel it is important that the health plan is a part of the process, so they must participate in the multidisciplinary team meetings where the level of care is being developed in order to facilitate quick and timely authorization of these services. Health plans will receive and have already received specific training on their role in attending the CMAT staffing meetings, including their voting rights. This will fully integrate them into the process from the beginning to the end, especially in that initial stages when it is first identified that medical foster care services may be needed. To ensure this is a smooth transition, initially and on an ongoing basis, the agency will continue to participate in staff and meetings to monitor the performance of health plans. So let's move on to service authorization of medical foster care services. So currently the agency authorizes all medical foster care services. So once the CMAT team makes a recommendation, the agency makes the final decision regarding authorization of medical foster care services. We are delegating that role to the health plans for their members. Health plans will be responsible for authorizing medical foster care services, including initial services, ongoing services, and level of care changes. Health plans will make its authorization criteria and process transparent for participants of the CMAT staffing, and service authorizations must be completed within contractually required timeframes. So that is 7 days for standard authorizations and 2 days for expedited authorizations. The agency will monitor all service authorization decisions made by the health plans, including the receipt of any denials for medical foster care services. We believe that the opportunity for denials will be fairly low because the health plans will participate in those CMAT staffing. And the goal is for, as always, for the team to reach consensus on the eligibility of that child and need for medical foster care services in the staffing. We will also make sure that the health plan is sending someone to the staffing, that case manager or care coordinator, and I'll talk about care coordination in a second, who has the authority to actually authorize services right then and there in the staffing. So let's talk about coordination of care. So the health plans will be required to assign a care coordinator for each enrollee receiving medical foster care services who will assist with all of the coordination of the child's care and will be available to provide 24/7 support. They will track leave days, the need for backup medical foster care parents. They will coordinate with the Florida Department of Health CMAT and medical foster care teams, and they will also help in coordinating discharges for medical foster care services. The care coordinator will be required to have pediatric experience, and the plan is for that care coordinator to interact and be integrated in the current process that is in place with the medical foster care social worker and nurses from the Department of Health. One question that we have received is whether or not the medical foster liaison will continue to provide 24/7 on-call support, and the answer is yes. The medical foster care liaison through the Department of Health, so that's your social worker and nurses, will continue to be able to provide that 24/7 on-call support. So again, as you can see, we are just overlaying additional care and support that will be available for that medical foster care parent and that child. If the child was already receiving private duty nursing services, which is the case for many of our medical foster care children, the plan is already contractually required to provide care coordination services for that population under our current contracts. So those plans will just continue to coordinate the private duty nursing services along with medical foster care. So you should not see introduction of an additional care coordinator into the mix for those particular children. So let's move on to the delivery of services and how that will be coordinated between the health plans and the Department of Health. So the health plans are required to work with the Department of Health Medical Foster Care Program to implement best practices and evidence-based guidelines that support the delivery of medical foster care services. The health plans and medical foster care staff will work cooperatively to ensure the child's needs are met. Engaging the health plans in this process alleviates the medical foster care social worker and nurse to more fully focus on the programmatic oversight of the medical foster care program. This means that they can review plans of care more routinely, provide more training opportunities for medical foster care parents, focus on recruitment and retention of medical foster care parents in coordination with DCF and the community-based care lead agencies, and work with the agency on establishing quality outcomes and performance measures in monitoring the continued efficacy of medical foster care services. So these are some of the ways that we believe this transition will help to free up medical foster care staff through the Department of Health to focus on other things, while the health plans step in to focus more on not only paying for the service, but also assisting in coordinating the service with the department. Okay, so I want to talk about the plan of care requirements. So currently in policy, the child must have a plan of care that is developed. This is something that is used by the medical foster care parent and is really their roadmap for the interventions that must be furnished to keep that child safely in that home setting. Health plans must develop and update the medical foster care plan of care every 180 days or more frequently if there's a change in the recipient's condition. Nothing is changing with regard to the importance of the development and upkeep of the plan of care. Again, this is the roadmap for the parent, and we know this, and so do the health plans. So the department and the agency has identified some opportunities in transitioning this role to the health plans. The health plans will have direct oversight of the physicians prescribing the services and interventions for these children. So it makes sense to us that they would be responsible for developing the plan of care that codifies those interventions and physicians' orders. The health plan will have to ensure that that plan of care is signed and dated by a physician who has experience serving children with complex medical needs, and they will have to develop that plan of care in concert with the medical foster care team at the department. They will have to share that plan of care with the CBC dependency case manager and the medical foster care parent. And last but not least, that medical director who is involved in the CMAT staffings and in ongoing monitoring of medical foster care services through the Department of Health will have the opportunity to review and weigh in on that plan of care. So again, we are overlaying additional opportunities for the health plan to participate in the process while keeping in place and intact many of the processes that are currently in place related to medical foster care. So this slide just gives a quick workflow overview of the delivery of care with medical foster care services. I will not read this slide. I will pause for a second and give you an opportunity to review each of the steps in the process. It just codifies what I just stated in some of the previous slides. Hopefully, after you have reviewed each of the boxes and have a moment to reflect on what I just presented, you will see again that the majority of the key features of how medical foster care services work today will remain in place. I want to move on to the provider network. So the health plans must ensure that they have an adequate network of medical foster care parents to ensure that the service can be provided with reasonable promptness. I want to stress the reasonable promptness piece. So this means that services must be provided in a timely manner without delay. The agency is providing health plans with information of all of the medical foster care parents and ensuring that the plans are contracting with the providers who are specifically serving their medical foster care members. Health plans must use an expedited enrollment process for medical foster care parents that have been identified as a viable placement option for an enrollee requiring medical foster care services. In addition to having an adequate network, the health plan will continue to have to ensure that there is backup parent availability, so that in the event that the medical foster care parent is unavailable due to illness or injury or for some other approved reason, that there is a substitute medical foster care parent who can step in for up to 30 days to provide services when the primary medical foster care parent is not available. This is not new policy, but we are requiring the health plan to comply with that provision in our Medicaid coverage policy. As it relates to provider reimbursement, the health plans have agreed to continue to pay medical foster care parents the rates established on the Medicaid Medical Foster Care Services fee schedule, which I showed you a few slides ago. Health plans will provide training to medical foster care parents on how to bill for services. We have been and will continue to work with health plans to ensure that the transition is a smooth one and that there is no disruption in payment to medical foster care parents. In terms of continuity of care, the same continuity of care requirements that apply for other Medicaid services apply to this transition as well. The health plans are responsible for continuity of care for new enrollees transitioning into their plan. That means that they are responsible for continuing to provide services that were previously authorized, whether that service was provided through the fee-for-service system or through another health plan, and they are required to do so for up to 60 days after the regional implementation date. In addition, the providers will continue to get paid regardless of whether or not they are participating in that plan's network, and they will continue to get paid for up to 30 days at the previous rate that the provider was receiving. Okay, so we are at the end of the presentation. I want to share some resources for you in case you have additional questions or would like additional information. So here are some helpful links. Here's the Department of Health Medical Foster Care information page. Here is also a link to the DCF Foster Parent Licensure information page. On AHCA's website, we have posted all of our coverage policies, which includes the Medicaid Medical Foster Care Services coverage policy and the Medicaid Medical Foster Care Services fee schedule. So you can find that on our webpage under our rules. We also have an outreach page that's dedicated to the SMMC implementation. This is where you will find this presentation in addition to other resources related to medical foster care services and some of the other newly covered services that are transitioning into the SMMC program. You will also find a presentation that provides a general overview over the SMMC program and our dental services managed care program. So you will find all of those resources on our SMMC outreach page, and this slide shows you the web link as well as where you need to click to find that information. Okay, if you have any questions, they can be emailed to this email address on the slide, flmedicaidmanagedcare@ahca.myflorida.com. I want to thank you for your time and attention during today's webinar. Again, if you have any questions, please submit it to the email address on this slide.